Today, it's my honor to introduce to you our speaker for today, Dr. Roger Blumenthal. Dr. Roger Blumenthal is the Kenneth J. Pollan Professor of Cardiology, Professor of Medicine, and the Director of the Johns Hopkins Cicerone Center for the Prevention of Cardiovascular Disease in Baltimore, Maryland. Dr. Blumenthal graduated with honors from both the Landon School in Bethesda and the Johns Hopkins University. He received his medical degree from Cornell Medical College, where he was awarded the Wise Prize for Excellence in Clinical Medicine. He then did his internal medicine and cardiology fellowship training at the Johns Hopkins University School of Medicine before joining the Hopkins cardiology faculty. Dr. Blumenthal was the 2018 recipient of the Landon School Anthony Kumka Distinguished Alumnus Award. He was the 2019 recipient of the Society of Cardiovascular CT Arthur S. Agustin, Cardiovascular Disease Prevention Award. His principal clinical and research interests involve strategies to improve cardiovascular risk assessments to identify those adults at elevated risks for their age and those at very low risks for cardiovascular disease, and the optimal management of atherosclerotic vascular disease. He is an expert in the pathogenesis, treatment, and prevention of cardiovascular disease. Dr. Blumenthal was also the co-chair of the ACC-AHA subcommittee that oversaw the updates of all the prevention-related guidelines, blood pressure and cholesterol, as well as the co-chair of the 2019 ACC-AHA primary prevention of cardiovascular disease guidelines. I could go on about his numerous positions and his numerous contributions in the field of research, but for the sake of time for the presentation, I will now hand it over to Dr. Blumenthal.
Omer, thank you so much for that really good introduction here. And I'm actually, let's see, trying to find my talk here. So when I hit share screen, it's not showing up on the background here, Thomas. So let's see if I can, basic, advanced. So let's say optimize screen sharing for video clip. So if let's see, is there a different way? So my talk is on, actually, let's see.
So we can see your desktop now, I think.
Okay, so let me click on now. And so the insider scoop, is that showing up okay?
Yes.
Perfect, all right. Little technical things, but this is it's a pleasure to be talking to you today. The title of my talk is The Insider Scoop on the 2018 and 19 Primary and Secondary Prevention Guidelines, and the subtitle, The Juice Was Worth the Squeeze. And it reflects a long period of work that we've done at Hopkins in collaboration with a number of groups. And it's been a pleasure to work with one of the stalwarts of VCU, Dr. J.D. Patel, over the last 7 years since he was in Baltimore as a resident. So the Johns Hopkins Ciccarone Center was founded in 1989 in memory of a close friend of mine, Henry Ciccarone, who was a legendary athlete and lacrosse coach at Hopkins, who died at the age of 50 after his third heart attack. And he was a dynamic coach and a great friend, and he was doing everything right after his first heart attack. And then a year later, he had a second heart attack in a different vessel that previously had just had 30 to 40% narrowings. And then about a year after that, he had sudden cardiac death, and likely it was his LAD that also had 30 to 40% narrowings that led to his demise. This is a picture of Coach Ciccarone. In the foreground, you can see those little lacrosse sticks on his Hopkins tie, and it looks like the assistant coach behind his left shoulder, Joe Cowan, is the one at higher risk for a heart attack. Looks like he's going to slug a referee. But my recollection in this Hopkins, Maryland game, no coaches were thrown out for being overly intense. Now, initially, when we started the Ciccarone Center, we really tried to focus more on the prevention of coronary artery disease, heart attacks. But what we've learned over the years is that the same strategies we're doing to lower the risk of heart attack and stroke also help prevent heart failure and abnormal heart rhythms like atrial fibrillation and peripheral arterial disease. And you've noticed, you may have noticed that our logo is that Hopkins Blue Jay with a headlamp, a stethoscope around his neck, and a lacrosse stick. So that's been a fun logo to have all these years. So let's go back in history and say what's been changing over the last decade. And in 2013, we had the ACC-AHA cholesterol guideline, and there were a number of misconceptions, one of which could be summarized in the phrase fire and forget, which basically means you start a person on, say, 20 milligrams of atorvastatin, don't need to measure anything, and that's all you really have to do about the lipids. But in reality, that guideline 7 years ago mandated ongoing lipid monitoring to assess adherence, treatment response, and the need for altering therapy. And another misconception of the 2013 guidelines was that if you had over a 7.5% risk of a heart attack or a stroke over the next 10 years, that you had to be on a statin. But in reality, a estimated risk at that level mandated a risk discussion between the clinician and the patient to really determine what would be appropriate therapy. And this is a humorous slide here. Where it talks about patients and physicians are used to having numeric goals. So things like A1C, TSH, uric acid levels, blood pressure, and for the clinicians in the office, SAT or MCAT scores, GPA to get into places like VCU. A golf handicap in the single digits is a good goal, and percent of first serves in. And one of the problems with the 2013 guidelines was that people thought we didn't have those goals as things to help guide us on what to do. Well, I helped lead a group at Hopkins that critiqued the prior guidelines in the Journal American College of Cardiology. And these were separate articles. The first one was by Seth Martin, who's now the director of Advanced Lipid Disorders Center, and Mike Blaha was a senior author. We entitled that one, What Was Done Well and What Could Be Done Better? And that raised some eyebrows among some of my friends who were on the guideline committee for the cholesterol guidelines. And then the title that we picked for the risk assessment guidelines really irritated some of the people on the risk assessment guidelines. We said headed in the right direction, but at risk for miscalculation. And one of the very outspoken members of the risk assessment guidelines wrote me a 6-page single-space letter telling me all these different things that were wrong with our article, and even questioning things about my mom's genealogy. So as you can tell, people sometimes don't like to get criticism of their work. But about a year later in 2014, I got a call from the leadership of ACC and AHA and said, we want you to be the co-chair with Dr. Mariel Jessup and help start all these subsequent updates of prevention guidelines, blood pressure, cholesterol, risk assessment, et cetera. And one of the best things I did, I think, was to recruit Sid Smith, who had been the senior author of the 2013 guidelines. This is a fun picture from his young days, and I guess he must have given up an MBA career to become a great interventional and clinical cardiologist. But there's a picture of Dr. Smith jamming from his high school days. Well, what are the take-home messages of the 2013 guidelines? And I've tried to simplify them so that everybody in the audience, no matter what your specialty is, will learn a lot from this. So number one, emphasize a heart-healthy lifestyle, because that reduces the risk at all ages and helps reduce the development of risk factors. And there's a lot of people in the audience who are 20 to 39 years of age, and the assessment of a lifetime risk facilitates the clinician-patient risk discussion and emphasizes lifestyle efforts that help to either prevent or to control what we call the metabolic syndrome or the pre-diabetic state. Number two message was that If you had clinical atherosclerotic vascular disease, you want to reduce LDL with a high intensity statin or maximally tolerated statin. The more the LDL is reduced, the greater the risk reduction. And our advice was to use a maximally tolerated statin to get the LDL down by at least 1/2. For number 3, if you were a very high risk individual, we actually brought back numbers. We said use an LDL threshold of 70 milligrams per deciliter to consider a non-statin. And we say these very high risk patients were people with multiple major events, or maybe a major event such as an acute coronary syndrome, a heart attack, plus another high risk condition such as diabetes, smoking, etc. We said it was reasonable to add ezetimibe to a maximally tolerated statin if the LDL remained at least 70. And if it remained above 70 on a maximally tolerated statin plus ezetimibe, we said you might consider a PCSK9 inhibitor, but pointed out that we didn't really have the great cost effectiveness data at that time. Number 4 deals with people who have severe primary hypercholesterolemia, meaning LDL of at least 190. Now, probably less than 10% of these people actually have one of the common mutations for familial hypercholesterolemia. And most people who have LDLs in this level have a polygenic cause. And we said if you have an LDL of at least 100, it's then reasonable to add ezetimibe. And then if it was still above 100, then you could consider a PCSK9 inhibitor. Number 5 was a little bit controversial, and I actually did not like the way we worded this, and I'll explain to you a little bit later. But the writing committee said if you're between 40 and 75 with diabetes and your LDL is at least 70, you really need to be on a moderate intensity statin. And if you had multiple risk factors, it was reasonable to reduce LDL by at least 50%. Now, part of the reason that I didn't like the wording of that was this article that I was part of. It was analysis of the MESA study, and it had 881 people with diabetes. And 37% of these diabetics had absolutely no coronary artery calcification. And there was an 11-year follow-up. And you'll see here that the diabetes group is in sort of the white collar bars. And it was about a 4% risk of a heart attack over the next 10 years. And when you looked at risk of heart attack or stroke, it was closer to 7%. But if you looked at the individuals who had A1Cs of less than 7.5% and estimated ASCVD risk scores of less than 15%, it was more in the range of anywhere from 2.5 to 5% risk. So I truthfully think if you have a patient who has diabetes, especially A1C less than 7.5 and may have had diabetes less than 5 years, if they have no coronary artery calcium, it's certainly reasonable if the patient is averse to taking a statin to hold off and let them work harder on lifestyle. Well, number 6 is if you had a middle-aged individual, what do you do in this clinician-patient risk discussion? Well, you're supposed to estimate a person's 10-year risk and look at risk-enhancing factors. You talk about the potential benefits of better lifestyle habits and what the statin could do. You can talk about potential for adverse drug interactions, but it all comes down to patient preferences and their values and shared decision-making. By that, I mean, you may have a patient who has had family members who have had a heart attack or stroke, or knows some friends or neighbors who have had that. And they may be more inclined to go on a statin sooner rather than later. And likewise, if they don't have any family members who've ever had heart problems, then they may be less inclined to go on a medication. Well, number 7 talked about these risk-enhancing factors that could be used in shared decision-making. And also, if your risk was still uncertain, you could consider a coronary artery calcium scan to resolve any uncertainty. Well, these risk-enhancing factors are listed here: a family history of premature atherosclerotic vascular disease, persistently high LDL of at least 160, metabolic syndrome, chronic kidney disease, factors specific to women like preeclampsia or premature menopause, chronic inflammatory disorders such as rheumatoid arthritis, psoriasis, HIV, high-risk ethnic groups like South Asian or Native American, and persistently high non-fasting triglycerides of greater than 175. Well, the European guidelines came out about 9 months after our guidelines did, and they also had some of the similar factors that would increase the motivation to start a statin. And they also included things such as atrial fibrillation, chronic kidney disease, obstructive sleep apnea, non-alcoholic fatty liver disease. And so these are other things that might sway you to start a statin sooner rather than later. But just because you have one of these high-risk conditions doesn't mean that everyone in that group is at high risk. If you look at one study of people with rheumatoid arthritis who are middle-aged, 60% had absolutely no coronary calcium and were very low risk over the ensuing 5 to 10 years. Another study looking at HIV patients whose Framingham risk score was close to 10%. Again, nearly half had no coronary artery calcium, and that group had a very low 10-year event rate. In another study of people with psoriatic arthritis, again, middle-aged, 58% had no coronary artery calcium. So again, not everyone with one of these risk-enhancing factors is automatically at high risk. So our group also said that other risk-enhancing factors or laboratory ones that, if were measured, would indicate that you'd be more inclined to treat: a high apolipoprotein B, a high hsCRP, a low ankle brachial index, or a high lipoprotein little a. Now here's a question for you, and Dr. J.D. Patel has been very involved in this research that we've been doing, and he's been working with our group to try to get a paper accepted in JAMA Cardiology, because a year ago he and colleagues presented this at the American Heart Association. So our question is, if a MESA participant in the multi-ethnic study of atherosclerosis was not on statin therapy and had 3 of those risk-enhancing factors, the prevalence of having no coronary artery calcium was, and many of you might have thought it was about 40%, since we talked about how important they were, but in reality, in Dr. Patel's work, it was less than 10%, and maybe closer to 6% of those individuals who had 3 or more risk-enhancing factors actually were in a very low-risk cohort. So number 10 said that if an individual was in that intermediate risk range of 7.5 to essentially 20%, if your decision about a statin use was still uncertain, then consider a coronary artery calcium scan. And the way that would work is that if you had no coronary artery calcium, we would oftentimes delay or withhold a statin. Maybe the exceptions would be if there's a cigarette smoker, potentially those with diabetes, though I think a closer look at that paper by Nathan Wong and Dr. Malik also would say that a low calcium score of 0 would be very reassuring. And potentially those with a strong family history of heart disease, you still may want to treat. And we said if you had a calcium score that was at least 100 or in the 75th percentile or higher, that would be a strong indication to start on statin therapy. And then we added 10A, which was assess adherence and percent response to LDL lowering medication plus lifestyle changes, and to repeat the lipids 1 to 3 months later after a treatment initiation or a dose adjustment, and then repeat anywhere from every 3 to 12 months, depending on the results and how sick the person was. So it's helpful to estimate the LDL reduction from baseline, and we routinely use what's called the Martin-Hopkins equation that my colleague Seth Martin developed with Dr. Stephen Jones. And the Quest labs, if you send your blood work to Quest, they automatically do that. And the Martin-Hopkins estimation of LDL is more accurate, especially if the triglycerides are above average or the HDL is low. So how does that work? Well, here's a classic paper by Dr. Welton and Dr. Martin. And what this is trying to show is that if you had an LDL less than 70, about a quarter of those individuals actually had an LDL significantly above 70. And if you knew that, then you would probably either intensify the dose of the statin or add ezetimibe. And that's typically what we found in study after study. Well, I'm a big proponent of making things simple, and I like this ABC approach. And the initial A stands for assessment of risk. And, the calculator is pretty basic. It's gender, age, race, total and HDL cholesterol, systolic blood pressure, whether they're on a blood pressure medicine or not, whether they have diabetes or not, or whether they're a smoker. And the change in the 2013 guidelines, while we switched from the Framingham score to the ASCVD risk score, is that the ASCVD risk score includes stroke. And I like this little cartoon in the bottom right where the doctor says, you're 57 years old. I'd like to get that down a bit. And I don't know if you figured out how to do that in Richmond, but we have it in Baltimore. And it emphasizes the point that the main driver of this risk estimation is a person's birth certificate, their chronologic age. And keep in mind that, this assessment equation doesn't take into account lifestyle habits or whether you're in the pre-diabetic state or not. So the current ASCVD risk score estimates the risk of a fatal or non-fatal heart attack or stroke. But I think the direction many of us are going in is that we'd like to have a global composite score. So you or I may tell a person they have a 20% risk of a heart attack or stroke, and they may not think that's bad. They may say, well, doc, that's an 80% chance. I'm not going to have a problem. But if we said their risk of a heart attack or stroke plus atrial fibrillation, heart failure, or revascularization was 50% or more, I think that would get their attention, and patient communication is so very important. Well, coronary artery calcium, to those of you who haven't had much experience with it, is really subclinical atherosclerosis. And we've had a lot of data that if you have a calcium score of 300 or higher, then you have about 10-fold higher risk than a person who has no coronary artery calcium at the same age and same risk factor status. And this is a nice slide that shows all that white calcification in the LAD and LAD diagonal and the start of a circumflex. And that correlates with that either type 5 fibroadenoma or type 6 more complicated lesion. So as Dr. Patel knows well, in our group in Baltimore with the Hopkins Chickaroni Center has worked with a lot of promising residents such as Dr. Patel. And this is one of my favorite studies with Dr. Michael Silverman, who was a resident at Hopkins. And this was published in the European Heart Journal before the 2013 guidelines came out. And what this is saying is that if you had even 3 risk factors for heart disease, or 4, if you had no coronary calcium, your event rate over the next 10 years was extremely small. But if you had just 1 traditional risk factor, but at a calcium score greater than 100 in the green, then your risk was 5-fold higher. So it emphasizes the importance of this litmus test of a coronary artery calcium scan. And in Baltimore, we've always liked the terminology, the power of 0. And that really came from this article by Michael Blaha and Khorram Nasir back in 2009 when Mike was a cardiology fellow. And we said in appropriately selected asymptomatic patients, the absence of coronary calcium predicts excellent survival with a 10-year event rate of mortality of just 1%. So if you had a person who had no coronary calcium, you could emphasize lifestyle therapies rather than pharmacotherapy. And maybe if they had some low risk squirrely chest pain, you wouldn't jump to a $2,000 stress nuclear test. You could give them a little bit more reassurance. And then we wrote this paper. It was a great privilege for me to work with Michael Blaha on the left, Khorram Nasir in the middle, and Matt Budoff. And we talked about a Bayesian approach. So if you had an asymptomatic person, then a coronary calcium score of 0 was very reassuring. But if you had someone that came into the VCU emergency room with stuttering chest pain, diaphoresis, and pain going down the left arm, then a coronary calcium scan, a result of 0, would not be that reassuring. Well, this was a classic paper that's cited many times in our cholesterol guidelines and our risk assessment guidelines. And Dr. Nasir was the first author. Harlan Krumholtz from Yale was the senior author. And the category on the left where it says recommend statins were individuals who had a 10-year risk in the range of 7.5% to 20%. And 41% of those individuals had no coronary calcium and had an extremely low event rate. And if you look in the middle category of consider statins, those were people in that 5 to 7.5% range, and 57% of those people had no coronary calcium with a very low event rate. And then Mike Blaha had another landmark publication where he said, we traditionally use risk factors to see if people should be on more medication, but can we de-risk people? Can we lower their estimated risk? And he looked at a variety of things: the absence of carotid plaque, a normal ABI, a normal CRP, a normal homocysteine, normal BNP, the absence of family history, et cetera. But it was really only the calcium score of 0 that decreased the estimated risk by 60 to 70%. So this is what we were just talking about. The conventional view of risk factors was that a blood test or some genetic information might indicate higher risks. So what would we do? We'd give a medication and push them on lifestyle. But the concept of a negative risk factor was if you had no coronary calcium, that would lower your risk, and it would give you more time to work on lifestyle and hopefully be able to motivate people more. Well, here's some good data from Matt Budoff that shows that both females and males, that if you had a calcium score greater than 300, your risk was pretty darn high. It was over 20%. But if you had no coronary calcium over that 12-year period, your risk was more in the range of 4%. So who are the people that we might think about for coronary calcium testing and primary prevention? Generally in people with a risk estimate of 5 to 20% who they're unsure of what to do. Maybe they're reluctant to be on a statin. Maybe they tried one and didn't tolerate it. In higher risk people, maybe, whether or not you add ezetimibe, they can't tolerate much of a statin, and maybe whether to add aspirin. So the highlights of the cholesterol guidelines were for secondary prevention: high intensity statin, get your LDL down at least 50%. And if you had side effects with high intensity, use a moderate intensity, but try to get your LDL down at least 30%. And we said in very high risk individuals already on maximally tolerated statin, it was reasonable to add ezetimibe if the LDL was 70 or above. Now this post hoc analysis by Aaron Bahula from the Brigham is very instructive, because it was really only the higher risk individuals that had a modified TIMI risk score of 3 or higher where you saw the big benefit of ezetimibe. And in this analysis, you got a point if you had a history of heart failure, hypertension, age of 75 or higher, diabetes, prior stroke, prior bypass, if you had peripheral arterial disease, CKD, or smoking. And if you had 3 or more of those factors, you actually had an absolute risk reduction of close to 6.5%, with a good number needed to treat of just 16. Well, what about a PCSK9 inhibitor? We said that if you were at very high risk and you were already on a maximally tolerated statin and ezetimibe, and then if your LDL was at least 70, that you might consider a PCSK9 inhibitor, but subsequent data indicated much more cost effective if the baseline LDL is closer to 100. Well, Dr. Seth Martin and I and Dr. Nasir wrote a nice editorial about this work from Mark Sabatine from the Brigham, where he was trying to identify which people would benefit most from a PCSK9 inhibitor. And Dr. Martin and I are both golfers. We like to talk about the sweet spot on the golf club. And we were trying, our title of our editorial was Finding the Sweet Spot. So what do I mean by that? Well, if you had your qualifying MI within 2 years, your absolute risk reduction was 3%. If it was more than 2 years, it was 1%. If you had at least 2 MIs, absolute risk reduction was 2.6%. It was significantly lower if you just had 1 prior MI. And if you had multi-vessel disease, then your absolute risk reduction was about 3.5%, as opposed to just 1% if you just had 1 vessel involved. And the ODYSSEY outcomes study, which looked at the other PCSK9 inhibitor, alirocumab, showed that almost all the benefit were in people whose LDLs were close to 100 or higher. Well, one question that comes up in medicine a lot is, what do you do about hypertriglyceridemia? And we wanted to emphasize it's so important to deal with lifestyle factors and improve them, and look at secondary factors and certain medications that may raise triglycerides. And in our guidelines, we said that we should consider persistently elevated triglycerides as favoring initiation or statin intensification. And if you had really high triglycerides, low-fat diet, really minimize refined carbohydrates and alcohol, strongly consider omega-3s, and fibrate therapy. But if you had moderately elevated triglycerides, think statin first rather than going for a fibrate or niacin. We also said in issues specific to women that if there was a pregnancy-associated disorder, that would increase the evidence base for this being a higher risk patient and starting a statin sooner. Women of childbearing age, important to use reliable contraception, and it's always good to stop unnecessary medications before one tries to become pregnant. And we advise stopping a statin at least a month before trying to become pregnant. We looked at chronic kidney disease as a risk enhancing factor. There's actually some nice data about statin plus ezetimibe in one trial. We said that if you have advanced kidney disease and are already on dialysis, that it was really hard to show a benefit of statin therapy. So that data is still somewhat in flux. Well, we're going through the ABCs. Now we hit D, and D stands for diet and weight. And on the left, we talk about what do you want to focus in on? Well, you want to increase fruits, vegetables, whole grains, nuts, legumes, seafood, and cut back on processed meats, refined grains, sweetened beverages, additional sugar, trans fats, dietary sodium, and saturated fat. But I really like the cartoon on the right where it says the latest in Homeland Security. The patient's spouse has figured out that her husband likes to raid the refrigerator at midnight or beyond, and she put a padlock on there, and he's carrying the Richmond newspaper that says 6 of 10 Americans overweight. So it's definitely a different strategy, but it is challenging. I think one of the big challenges is that people get hungry. And if a lot of us in the audience have tried to say we want to get our weight down 5 pounds, 10 pounds, one point or another. And I think it's so important to decrease the speed of eating and to focus in on the foods that may fill you up more. Well, the European guidelines came out and they said we should be aiming not just for an LDL less than 70, but less than 55. And you might say, well, where did that come from? Well, the cholesterol treatment meta-analysis indicates that you could decrease the events by close to 30% by going from an LDL of 66 down to 50. The Improve-It study showed a more modest decrease of 6 to 7%, but the 2 PCSK9 inhibitor studies showed decreases of about 15%. So that's why the European guidelines are more aggressive than the US guidelines. And here's a good graph that I think is so helpful, that in the individuals who are at high risk, the European guidelines recommend targeting an LDL of 70 or below. And that would include people with moderate chronic kidney disease, people with diabetes without target organ damage, with diabetes of at least 10 years duration. And they would say that very high-risk individuals, your LDL target would be less than 55. And they would include people whose GFRs are less than 30 there, and people with type 1 diabetes of at least 20 years. Now, our guidelines came out the same American Heart Association meeting as one of the blockbuster studies, namely Reduce It. And to refresh your memory, these were people who were at least 45 years of age, established cardiovascular disease, or people who had diabetes with at least one risk factor. And they needed triglycerides less than 500, and they needed an LDL of less than 100. You were excluded if you had severe liver disease or advanced heart failure. And in this composite endpoint, event rates went from 28% down to 23%. That's an absolute risk reduction of about 5%. And then if you look at the key secondary endpoint of cardiovascular death, MI, or stroke, the absolute risk reduction was about 3.6%. Now this slide shows that there's a trend for greater risk reduction when you have triglycerides of 250 or higher. And there the relative risk was 0.6, so 40% relative risk reduction. And I think that's important to remind yourself about. But this analysis showed that even triglycerides in the 80 range or higher, you showed about a 25% risk reduction. Now the data in the US subgroup was even more striking, where we went from 32% down to 23% for that composite endpoint. And for cardiovascular death and MI, it went down by about 4.5%. So it's almost too good to be true. And remember, these people are very well treated, generally on at least moderate dose statin. Now, this last analysis in the US subgroup is very interesting, because if you're looking at mortality for secondary prevention, there was a mortality decrease of 29%. But for primary prevention, it didn't quite reach statistical significance, though it comes quite close. And sometimes, at least here in Baltimore, it's really difficult many times to get approval for icosapent which is purified EPA, unless you're in that secondary prevention category. So let's switch gears. We're in the final home stretch. We'll talk a little bit about the prevention guidelines that I had a chance to co-chair with former AHA President Donna Arnett. And as Dr. Patel knows, we like to use this ABC approach. A stands for assessment of risk, and then under that, antiplatelet anticoagulant therapy, B, blood pressure, C, cholesterol and cigarettes, D for diabetes or glucose management, D for diet and weight, and E for exercise and education. So when we're talking about assessment of risk, we want to emphasize shared decision-making. It's really the patient that makes the final decision, but we want to try to present the patient with the best information. And we use a team-based approach to prevention. I think it's important for those of us who work with people who have a lower socioeconomic background to always think about social determinants of health. And Medicare uses this 5-domain screening tool. Does the person have housing instability? Do they have a safe place to live? Can they buy healthy food? Do they have trouble with transportation? Can they afford their utilities? And is there a safe place to walk in their neighborhood? Well, in primary prevention for blood pressure, we summarized it pretty simply. Think less than 130/80. And after that, weight loss, heart healthy diet, sodium reduction, dietary potassium supplementation, increase exercise, and cut back on alcohol. And then we also said that if you were a relatively low risk, an ASCVD risk score of less than 10%, you wouldn't even really be thinking about adding a medication unless the blood pressure was greater than 140/90. But if you were a high-risk person, namely had diabetes, chronic kidney disease, an ASCVD risk score of at least 10%, then we'd think about medication for blood pressure above 130/80. Everybody gets healthy lifestyle, but your estimated risk determines when you might start thinking of adding medication. Well, C, for cigarettes, we've tried to emphasize that you should probably use either bupropion or varenicline and add some sort of nicotine replacement. And this slide goes over patch, gum, lozenge, inhaler, etc. So the combination is better than just one alone. For diet and nutrition, it's pretty simple. Emphasize vegetables, fruits, legumes, nuts, whole grains, and fish. Cut back on saturated fat. Reduce the amount of dietary cholesterol and dietary sodium. You want to minimize processed meats, refined carbohydrates, and sweetened beverages. And you want to try to minimize the intake of trans fats. And we gave that a class 3 harm recommendation for trans fats. So I think it's important when you have a person who wants to lose weight, you want to tell them it's a comprehensive lifestyle program. You maybe want to start with decreasing their daily calories by 400 or 500 calories a day. And, if they start off at 3,000 calories, then, you're trying to get them maybe down to 2,000 calories. If they start at 2,000 calories, maybe you're trying to get them down to 1,400 calories. You want to increase physical activity to at least 150 minutes of brisk activity a week. But I usually tell people, if you're trying to lose weight, it's really more like 200 minutes per week of some brisk activity. And we thought it's important to monitor weight, and WC is waist circumference. I think that gets people's attention. If you have diabetes, you want to think about not only A1C, but a comprehensive nutrition plan. You want to think about increasing exercise, and you want better glycemic control, and you want to improve weight. Now, E for exercise. You may be a few music fans and basketball fans out there in the audience. So this is two of the most famous MJs, Michael Jackson and Michael Jordan on the left, maybe playing a little basketball. And the dance routine, I think Michael Jackson had a little bit more experience than MJ 23, but exercise, getting your heart rate up is so very important. Well, as we head in the home stretch, how do we think about these primary prevention guidelines? So A is assess risk. Use the pooled cohort equation, and then you can personalize with risk enhancing factors. If you're still uncertain, refine by coronary calcium. For antiplatelet therapy, we need to rethink aspirin. Maybe we still might give it in smokers, maybe people with a family history of early MI, maybe people with high LDLs, people with high CVD risk scores, or at least moderate coronary calcium. B for blood pressure. Normal is really 120 or less, as opposed to 140. We focus on lifestyle first, and if you're high risk, we might add medication as low as 130/80. For cholesterol, we want to discuss the statin if intermediate risk, and we can refine that risk assessment with coronary calcium. If they have no coronary calcium, that's a very reassuring. Cigarettes, never too late to quit. Start with motivational interviewing, and then think about combination pharmacotherapy. For diabetes, we want to screen high-risk adults, lifestyle modification for all. Probably from a cost-effective point of view in primary prevention, metformin would be first, but we have some very good data, as everyone in the audience knows, about SGLT2 inhibitors and GLP-1 receptor agonists. For diet, eat vegetables, fruits, nuts, legumes, whole grains, and fish. And exercise a minimum of 150 minutes of moderate intensity exercise, and think about mobile health strategies to motivate our patients more. So I just want to turn your attention to a really nice review article that one of our stars, Aaron Mikos, along with Dr. Bill McAvoy, who's now back in Ireland, did in the New England Journal with me. And this was really a tour de force for Aaron and Bill. And it talked about everybody, we promote a healthy lifestyle, we share decision-making, measure the risk factors, of estimate a person's risk. And statins are first line if they have atherosclerotic vascular disease. You get that LDL down by at least 50%. It's automatic if you have really high LDLs in the 190 range or higher. The guidelines say if you have diabetes, start a moderate intensity statin. But if you're really in that intermediate risk range, you want that clinician-patient risk discussion. So how did I summarize this when we presented this 2 years ago at the AHA? I said numbers matter. We now brought back thresholds and targets. Lower LDL is better with proven therapies. You want to use a high intensity statin, get at least a 50% LDL drop. We now have a threshold LDL of 70 for non-statins. Ezetimibe first, and then if you're still above 70, consider a PCSK9 inhibitor. For familial hypercholesterolemia or people whose LDL is above 190 for other reasons, trying to get it down below 100. And we also said because the Friedewald method limitations, the Martin Hopkins method of estimating LDL is better. In terms of risk prediction, the power of zero, coronary calcium score could be the best tiebreaker if there remains uncertainty. We can personalize things and identify a very low risk individual. Remember, coronary calcium is a decision aid and not screening for everybody. We want to focus treatment on those who will benefit the most. So what are the take-home messages? The best tiebreaker to determine eligibility for statin therapy is a coronary calcium scan. Remember, the risk estimator is an educated guess, and the risk enhancing factors can guide the discussion, but the coronary artery calcium score is most important. Numbers matter. You want to remeasure numbers to reassess adherence and need for proven non-statin treatment like ezetimibe. And while the European guidelines favor lower LDL targets and goals, and they've expanded high-risk primary prevention eligibility, the US guideline actually mirrors the clinical trial threshold concept for adding on therapy. So my final slide is this one. We talked a lot about the ABCs, but the AHA likes to use Life Simple 7. So I would always say, B for blood pressure, C for cholesterol and cigarettes, D for diet, a healthy diet and weight, maintaining a normal weight, and also trying to optimize blood sugar, and E for exercise. So I think those are the best ways for us to figure out how to put these ABCs of prevention all together. And for that, I just want to thank you for your attention, and happy to answer any questions you might have.
Well,
Or maybe
thank you, Doc.
I'll have you sort of lead off if you want to. I don't know if there's anything in the chat box that you wanted to start with.
Let me see. I don't see anything in the chat yet, but Dr. Blumenthal, I actually had a question for you. Talking about coronary calcium scoring, if you had a patient, so you would recommend a statin, but given patient preference, you get the calcium score, it's 0, so you decide not to potentially. At what point would you reassess and say it's been X amount of years, maybe we should rehab this conversation, if they're supposed to risk profiles otherwise remain unchanged?
Great question there, Amar. I think Mike Blaha is a senior author on a paper that really addressed this so well from the multi-ethnic study of atherosclerosis. So people in the audience may just want to, in PubMed, look up Michael J. Blaha. And what we concluded was that, in 5 years for the average person in MESA, about 20% of the people go from no coronary artery calcium to at least some. And so rechecking a coronary calcium score in the 5 years or more is reasonable. If you have a higher risk individual, let's say, maybe they have diabetes and they haven't improved their lifestyle habits that much, or they have a prominent family history, we then said, you might reconsider at 3 years rather than 5 years with another scan. But, I think you and I would tend to try to treat these people earlier if they haven't made the significant lifestyle improvements. But for most people, that 5-year follow-up with a coronary calcium scan is what we go with in our recommendations.
Thank you so much. And I believe we have a couple of questions in our chat. Dr. Syme asks, can you please comment on the role of high intensity versus other exercise and the risks?
Great. So Dr. Syme brings up a really good question. And I think so much depends on what a patient's been used to doing. If you have a person who hasn't been very active, you're probably not going to want to push them to train to get to a 10-minute mile over the next few months. But I think this gradual increasing of exercise, and we tend to try to do this more intermittent high intensity, where you may have people walking on a treadmill or outside, and then maybe every 5 minutes for a minute or two, increase the pace to tell them, let's do some speed walking, and let's get your baseline speed up higher just by improving your fitness level. So it's clear that the more exercise, brisk activity that a person does, the better. But, as someone who injured their knee while jogging around the local track of the high school at the start of the pandemic, there are some things that we may want to avoid with a lot of running and things of that nature. So I think that's a good way of thinking about it. More exercise is better, but sort of a discussion between the clinician and the patient about what to do.
Thank you so much. And we do have an influx of questions now coming in, actually. So one question is, can you expand on your comments about ESRD in late stage CKD patients and how to best treat/assess them?
So Dr. Dow brings up a real good point. I think while the older data said that if you're on dialysis, probably a statin is not going to be cost effective, there have been some other analyses that have said that if there's still a concern about ischemic heart disease, another MI or a stroke, then it's certainly reasonable to give a statin. So that's sort of a work in progress. And I think, in the past, people who went on dialysis, their life expectancy was a lot shorter than it is now. So I think that's part of the discussion is with patients trying to decide whether to treat everyone for their lipids with a statin if they're on dialysis or not. I still tend to give statin therapy, but tell them that the absolute risk reduction is not as great as I would like. So it looks like there's another question I can take here. It says, a question not directly relevant, but I know some of your mentees who've had a successful career. What advice do you have for other mentors and mentees? And thanks so much, Rehan, for that question. And I think it's so important, those of you who want to stay in an academic setting, and even if you're not, it's so good to be able to mentor and give advice to people who are younger than you. And I think a good mentor is someone who tries to make the younger individuals he or she works with more successful. And you take a lot of pride in those individuals who have worked with you and gotten some advice, and you help them get their own areas of expertise. So, people like Mike Blaha, J.D. Patel, Quorum Nasir, Peter Danye are individuals who I've worked with in the past, and I'm just always thrilled when they get a new paper or honor. And I think that's so important. And you want to make this fun. We're only on this earth for a limited amount of time, and you want to try to get along with people and move things forward. It's been a divisive election season, but we're all going to have to work together, and whoever becomes president, you need to move things forward and not be in gridlock. And I think the same thing with academic medicine is that there's a number of people I work with that I'm good friends with who in years past would criticize our team's work and say, we've gone far beyond what the evidence shows. And I think, you want to try to find a common ground and move forward. So hopefully, Rehan, that addresses that some. Another question is, any thoughts as to the use of bempedoic acid in the future for non-statin therapy? And I think that's a great question. And as many of you know, bempedoic acid, rather than being an inhibitor of HMG-CoA reductase, inhibits another enzyme that we refer to as ACL. And bempedoic acid is similar to ezetimibe. It may lower LDL 15 to 20%. When you combine a bempedoic acid with ezetimibe in one pill, you get a reduction in most studies of about 40%. So clearly there's, of all the patients I see, it may be 3 to 5% are truly statin intolerant, can't take any statin. There's also a good number of people that maybe can only tolerate a low dose statin every other day, for instance. And, adding something like ezetimibe alone or ezetimibe plus bempedoic acid will lower the LDL down there significantly. And I think more and more data suggests that lower numbers are certainly better. It looks like Dr. Sternberg said, how do you counsel young patients less than 40 if they have no cardiac risk factors but want to start statin therapy very early due to family risk factors and knowledge about the benefits of long-term statin use? And thank you, Dr. Sternberg, for that question. Recently, there's been a few articles on acc.org, which I encourage the audience to just sign up for free. And we've talked about that, there are quite a number of people who develop atherosclerotic vascular disease in their 30s, 40s, and 50s, and especially those people with a family history of heart disease. Let's say their LDLs are 140 to 170, but they don't get to that 7.5% 10-year risk threshold. Well, I think it stands to reason that the longer you can get their LDL down in the more optimal range with LDLs less than 100 or less than 70, the lower their lifetime risk will be of having major atherosclerotic vascular disease. And while we don't usually do a coronary artery calcium scan in men less than 40, we might consider it in people in that 35 to 40 range if they have a prominent family history of heart disease. Amar, I think those looks like the vast majority of the questions. I don't know if you want to have the final word or if you have access to any other questions there.
No, Dr. Blumenthal, I think that was it. So I just want to say thank you again for volunteering to give these great talks. I know you're a busy man. So if there's no more questions, I think we can probably end it there.
Well, great. I look forward to talking to some of the trainees and fellows in about 10 minutes. Thanks so much.
Perfect. Thank you so much.
Have a good day.
Thank you.